Everyone, my name is Kinna Thakarar. I'm an infectious disease and addiction medicine doc at Maine Medical Center, and the title of my talk is Injections and Infections, Understanding Harm Reduction Utilization in Maine. I have no disclosures other than the funders listed here. And here's an outline of the talk. I'll briefly review the epidemiology of injection drug use associated infections, also discuss syringe service programs or SSPs, review the Rural Heart Study or the Rural Harm Reduction Access and Regional Trend Study that we just completed here in Maine. And then finally discuss the ongoing COVID-19 study and leave some room for discussion at the end. So nationally, we're seeing rising rates of hospitalizations, particularly in bacterial infections in the setting of injection drug use. As you can see from the table here, in the first column are various types of injection drug use associated infections, including endocarditis, which is a very serious heart infection. And the researchers compared the number of hospitalizations in 2002 compared to 2012. And as you can see from all the different types of infections, hospitalizations are rising in each category. And this was a study published by Dr. Nenninger and our team in Maine, using also a similar national inpatient data set, looking at opioid-associated infective endocarditis. And we looked at urban versus rural areas. So if you look at the graph on the right, the urban areas are in gray, the rural areas are the black boxes. And we looked at the time period of 2003 to 2016. And as you can see from the table on the left, the rate of opioid-associated infective endocarditis cases rose rapidly in urban areas, but also in rural areas. The rate went from 0.28 per 100,000 to 3.86 per 100,000 over time. And I think this really speaks to the need to increase access to not just substance use disorder treatment services, but also harm reduction services in rural areas. And this is a study we published locally that was led by Dr. Ramirez, who's now a cardiology fellow, looking at the cost of infective endocarditis. And this was a study looking at 3 years worth of data in patients with endocarditis at Maine Medical Center. And we looked at the hospital charges. The second column is the cost for injection drug use associated and infective endocarditis. And as you can see, the median hospital charges were $150,000 per patient. And over time, around $5 million, sorry, was paid by Medicare over 3 years. So these infections are costly, and they're also obviously affecting our patients, and there's potentially poor outcomes. We also know that the rates of acute hepatitis C are increasing. These data are a few years old, but are what's available through the Maine CDC website. From 2013 to 2018, you can see Maine is sort of the teal color there, and there was a 314% increase in acute hepatitis C, and Maine had the 9th highest rate of acute hep C in US at the time. And rates of acute hepatitis B are also on the rise. From 2015 to 2018, there was an almost 500% increase in acute hepatitis B cases in Maine. Again, much higher than the national rates. And many of these cases were attributable to injection drug use. So very briefly, I'm going to talk about syringe service programs, or SSPs. I think most of you at this conference are probably very familiar with them. But just a quick review, syringe service programs, or SSPs, are known to effectively counsel clients about safe injection techniques. There's a lot of data showing that they can reduce the transmission of infections, particularly HIV. There's some data on hep C as well. They also deliver overdose prevention education, administer vaccines to clients, and they can facilitate referrals for treatment for opioid use disorder if and when people are interested. So these are some data published recently looking at the number of HIV cases averted by an SSP legalization. And these were actually published from my home city, Philadelphia. So they looked at, if you look at the graph here, the dates were 1984 to 2014, and the orange line represents actual new HIV cases, and the red line indicates when SSPs were legalized, sorry. And so The blue line is actually the forecast of new HIV cases. And they found through this study that almost 11,000 HIV cases were averted over this 10-year time period. And this is very significant given the cost of HIV infection. And this is obviously a lifelong diagnosis for folks. So this is just one of the many studies that has shown that SSPs can help avert HIV cases. Now, regulatory barriers around SSPs can really vary by state. There's this one-for-one needle exchange, which is sort of like it sounds. You bring in a dirty needle and syringe and you get one in exchange for that. That can obviously be really difficult for people who have to travel far distances to get to an SSP. And this can really be a barrier for folks. Now, fortunately, in the setting of COVID, this one-for-one needle exchange has been eliminated. There's also various drug paraphernalia laws, which vary by state. And in Maine, you can see the laws here, where if you possess, 11 or more needles, people can get in trouble for that. And so, again, these regulations can vary by state, but they are prohibitive. Now, I think most of you are also probably familiar with supervised injection facilities, but just another very quick review. So supervised injection facilities, or SIFs, are places where people can go to inject their pre-obtained drugs under supervision. And these pictures are actually from the SIF that I visited in Toronto a few years ago. So as you can see, people can get clean supplies and they have a safe place to inject. And there's tons of studies around SIFs. They've not yet been uh, adopted yet in the United States, although Philly might have one soon, let's hope. But what we know so far about SIFs is that they reduce mortality, they reduce infections, they've been shown to reduce costs, and they also have been shown to reduce drug use and increase treatment uptake. And that sort of just wanted to set the stage for the rural heart study, which is what I will talk about over the next few slides. So the idea for this study, Rural Heart, or Rural Harm Reduction Access and Regional Trends, really came from this infectious disease and substance use disorder syndemic that we're seeing nationally, but especially in Maine. So I'm part of this substance use disorder working group through our professional society, the Infectious Disease Society of America. And we came up with some policy recommendations on the state and federal level to help prevent and treat some of these injection drug use associated infections. And I left the reference there in the corner if anyone's interested. And so one of the recommendations was to expand SSPs and also consider supervised injection facilities. So we really wanted to look at sort of what was the landscape of people using SSPs in Maine. And so at the time that the study started, the green stars here represent the SSP sites, and the orange counties indicate the counties that were deemed high risk for HIV hepatitis outbreaks by the CDC. And as I mentioned, Maine had some of the highest rates of acute hepatitis B and C. About 10% of HIV cases were thought to be related to injection drug use. And also Maine still has one of the highest rates of drug overdose deaths. So the aims of our study, Rural Hearts, the first are here. The first aim was to characterize knowledge, attitudes, and practices around safe injection techniques. The second aim was to identify factors predicting syringe service utilization and the uptake of other services. And we hope that this information would help provide some more insight into how people are using SSPs and also identify barriers. And our main hypothesis was really that distance from SSP would be an important predictor of utilization. So here's our study design. We recruited participants from 4 different hospitals in Maine that you can see here, and all participants had an injection drug use associated infection. And over an 18-month time period, we enrolled a convenient sample of 101 inpatients, and we collected data through a survey that was done on a laptop, as well as electronic health record data collection. And here are the outcome measures. The primary outcome was SSP utilization, and we also looked at uptake of clean needles and syringes. You can see some secondary outcomes that we also looked at here: clean drug equipment, naloxone, and medications for opioid use disorder, although for the purposes of this talk and the interest of time, we'll be mostly focused on the primary outcomes. So here are the results of the Maine analysis. As you can see from the bar graph in red, that 65% of the participants reported past 3-month SSP utilization. And interestingly, when asked about using clean needles or syringes every time they injected, about 10% of participants reported they used a clean needle or syringe each time. And this is just a snapshot of some of the variables that we looked at in the study. So the first column are a few different types of demographics. The second column is the overall study population, 101 participants. Oops, sorry about that. And the third column is the 65 SSP utilizers. And the fourth column are the 36 participants who denied any recent SSP use. And generally speaking, this study population was young. Median age was around 35. I'm considering that young. Female, mostly white, and about 50% of participants were experiencing homelessness. And notably, as highlighted there in red, a majority of the population, 57%, lived more than 10 miles from an SSP. And of the 36 participants who denied any recent SSP use, 81% of them notably lived more than 10 miles from an SSP. As I mentioned, we looked at different outcomes, including medications for opioid use disorder, naloxone, clean drug equipment uptake. And as you can see highlighted in red at the table, generally speaking, those who reported past 3-month SSP use had higher uptake of all of these services compared to those who did not use SSPs frequently. And we asked participants a lot of questions about what drugs they were injecting, how they were injecting. And as you can see from this table, generally speaking, most people were injecting opioids, but several participants did report that stimulants were their drugs of choice, about 30%. And I think this is really reflective of what we're seeing on the national level as well. And I think, because we don't have great treatment for stimulant use, I think this really speaks to the need for harm reduction services in particular in order to prevent infections from injecting stimulants. And we also looked at many different types of injection practices. Now, this is a very busy slide, but I just wanted to, again, provide a snapshot of what we looked at. So the colors in orange represent something that was done rarely or never. The colors in yellow or sometimes, green was half the time. And generally speaking, people are not using clean needles, filters, cookers, clean water, et cetera, consistently. And as an ID doc, I found these two practices really interesting in that, majority of participants reported licking their needle during the drug injection process, and many were still, re-injecting the needle, which again, we're seeing a lot of infections from skin flora, oral flora. So as an ID doc, these are practices that I like to discuss with my patients in order to try to prevent some of these infections. We also looked at something called a bacterial infections risk scale, or the BERSI scale. And I won't go through the whole scale in the interest of time, but there are two interesting practices here, which were that most participants reported that they did not have an opportunity to wash their hands or use alcohol pads before and after injecting their drugs. And this is a map that was created by one of my colleagues in Maine using our data, in Boston, sorry, using our data. And in terms of syringe acquisition, as I mentioned, 65% of participants reported using SSPs in the past 3 months. However, when we asked people how frequently they were using SSPs, 36% reported that they used an SSP frequently. And again, more than half of the participants reported trouble accessing SSPs, and they lived more than 10 miles from a program. And on the map, you can see here the SSP sites that were circles, red circles, and then with sort of this 10-mile buffer zone in the red circles around. So you can just see, even looking at the map, how far people need to travel to get to SSPs. And again, this is at the time of the study. I know the landscape has changed a little bit, and we'll talk about that. Now, in terms of syringe disposal, we found that about 70% of participants reported keeping needles to reuse on themselves. And as you can see from the picture on the right there, that's what a needle looks like when someone injects repeatedly with the same needle. And this is obviously caustic to people's veins and can put them at higher risk for infections. About 30% of participants reported disposing a needle in the trash, and 27% reported returning their needles to a syringe service program. We asked people about overdose risk and prevention, and about 48% of participants reported naloxone uptake, which we defined as naloxone being used on them or them using it on someone else in the past 3 months. And most reported getting their naloxone from an SSP. If you look at the pie graph on the left, we asked participants if they'd ever injected alone in the 30 days prior to hospitalization, and 90% reported this. And I think that speaks to also the stigma that can be associated with substance use disorders, and also speaks to the high overdose risk in our study population. I had mentioned SIFs, or supervised injection facilities, earlier. 86% of our study participants supported having a SIF, as I mentioned, not yet adopted in the United States, but SIFs have been used elsewhere around the world. And if you can look at the pie graph on the right, 95% of our study participants were interested in mobile harm reduction units in order to get their equipment. As I mentioned, we did look at other outcomes, which included treatment with medications for opioid use disorder. So you can see from the pie graph on the left, 66% of our participants were on medications for opioid use disorder prior to hospitalization. And I thought this was really interesting because, again, it speaks to the need for harm reduction services. Patients were on treatment, but also, we don't have for opioid use disorder, but many were injecting stimulants. And so, we need people to have access to safe equipment. And from the pie graph on the right, you can see the different types of medications for opioid use disorder. Most of our participants were on buprenorphine. So when we looked at our analysis, we found that controlling for all of the variables that you see here, homelessness, history of overdose, having a primary care doctor, being female, people who injected drugs were 5.5 times more likely to use an SSP if they lived within 10 miles of one. So it really showed us that distance is truly a barrier to accessing SSPs in our state. And so from this study, we concluded that unsafe injection practices were common. There were specific behaviors and techniques where maybe more counseling could be helpful, but obviously also having access to clean equipment is needed. And there was a lack of consistent SSP utilization, and that seems largely due to the distance that people need to travel in order to get clean equipment. So next, I'm going to talk very briefly about our COVID-19 study that's still ongoing, but I wanted to share some preliminary results for this conference. So just some background, as I think most of you know, overdoses among people who inject drugs, among people in our community, are rising during COVID-19. These data are national data showing on the bar graphs in red show pre-stay-at-home orders. The bar graphs in yellow show post-stay-at-home orders and the number of overdoses. So there's been nationally an 18% increase in overdoses. And these are overdoses that are reported. I know particularly talking to folks in Maine, there's tons of overdoses that are happening that are not necessarily being reported. So, these numbers are probably even higher, which is concerning. So the study that we're doing right now, I've listed the aims here. The first aim is really to understand the effects of quote unquote social distancing on overall health for people who inject drugs, with a focus on facilitators and barriers to accessing harm reduction services during COVID-19, and thinking about lessons learned from service delivery during this pandemic. And we also wanted to examine differences in acute care utilization at Maine Med before and after social distancing measures were implemented. But for the purposes of this talk, I'll really be focusing on the facilitators and barriers to harm reduction services. So our study design, this is a mixed methods approach for um, our first aim, we did semi-structured interviews with 30 stakeholders, which included providers, community partners, and people who were actively injecting drugs, or some of whom were in recovery. And we used a modified grounded theory approach. And what we found so far from this study is that, COVID-19 has really just shed light on problems that predated COVID-19. As you can see from the first quote here, uh, I use a lot more. It's a lot harder because of stress. Even going into a public place, using a bathroom when you haven't bought food there, they look at you like you're the devil. What's being told to us is just the increase in domestic violence and sexual assaults, a lot of assaults towards younger people who are out on the street. So these two quotes really show that old issues have been exacerbated during the pandemic. Things such as homelessness, domestic violence, sexual assaults, food insecurity, stigma, all of these things are under the microscope now. And the other problem also is that people may not be prioritizing COVID-19. As you can see from the quotes on the bottom there, one person said it's almost like a luxury in a way to be able to think about COVID and stay safe. Another person said, I have a lot more things to be afraid of than COVID-19 on a day-to-day basis. So again, a lot of people are just focusing on their basic needs and not really thinking about COVID-19. And this table is a bit busy, but I just wanted to, again, sort of highlight some of the findings that we found. In the first column are different types of services. The second column is different facilitators that we found. And the third column are barriers to care. And some of the ones I wanted to highlight, particularly for facilitators, was the mailing of equipment to clients, and also the relaxation of different rules, such as the one-for-one needle exchange that I mentioned earlier, and also having much more mobile outreach now is something that a lot of people are recognizing that these things are very helpful. And in terms of barriers, um, really, some of the main things that came up are things that are physical barriers because of COVID itself, the social distancing, the masking, no, not being able to have face-to-face encounters, which, really it uh, is hard for people to trust people if they can't see them face to face and have those interactions. And I don't have time to go through all the themes that we found so far, but I wanted to highlight these few. And one was that, low barrier is something that's essential for harm reduction services, yet efforts to slow the transmission of COVID-19 are often barriers in themselves. So, as I mentioned, the need for physical distancing and masking and, um, all of these things are physical barriers, and also that makes it harder to be low barrier and open to folks. Um, Again, as I mentioned, relaxed policies has been very helpful. What we're finding from our interviews, trust as a facilitator is something that's come up a lot, especially from people who are actively using drugs right now. Um, and again, having that face-to-face time or not being able to have that face-to-face time is sometimes an issue. And also resilience is something that has come up a lot, despite all of the challenges that COVID-19 has posed, really, community partners are putting themselves on the line oftentimes, um, and really just showing up for people. And I think that's being recognized among community partners and also recognized by the people who are actively injecting. So this is a quote that I just wanted to share from one of our interviews with the community partners. It's a long quote, so just bear with me. But I think this really is a nice quote to reflect some of the lessons and opportunities to move forward here. So as with a lot of things we've learned through COVID, whether it's kids that can't eat unless they're at school, or all these social issues that we've learned, that we've ignored for a long time. Now they've got a microscope on them. And I think it would be a disservice to all of us if once this is over with, if we don't really look hard at these issues and go back to the drawing board. I think we could have done better if we had been a little bit more progressive in our harm reduction approach and then been a little bit more like other countries and really truly be focused on reducing the spread of diseases or illnesses and reducing overdose. We need to have true harm reduction and really start to look at things like safe consumption sites and more services, even for active folks. So there were certainly some limitations to this study that we're doing. You know, it may not be generalizable to other areas. Maine so far has had a low COVID-19 prevalence compared to other states. Um, Again, our state is rural, so some of these challenges may not be applicable to other areas. We only interviewed English speakers, so obviously non-English speakers might have additional barriers or facilitators that we haven't identified. And because all of these interviews, particularly with folks who are actively using were anonymous, we don't have much demographic data on the folks that we have perspectives from. And again, these are all subjective experiences that we're sharing here. So from our COVID-19 study so far, what we've found is that other issues that preceded COVID have really been exacerbated during the pandemic. As I mentioned, homelessness, sexual assaults, stigma, all of these things are people, are still very much experiencing. We also identified several barriers and facilitators to accessing harm reduction services during the pandemic. Again, some of the main facilitators have been those relaxed policies, um, and also mobile outreach has been key. Some important themes, as I mentioned, have been resilience and that community partners really are continuing to do service delivery despite all of the hurdles that they're facing. And again, trust has been an issue. It's hard to build trust with folks if you don't have direct contact with them all the time. So some of the implications of our work so far is that, basic needs really need to remain a priority, and that's, housing first and addressing homelessness and food security and all of these things. Um, Winter is coming, and these things, we really need to address them. Otherwise, COVID-19 is also going to get worse in our state. Also, thinking beyond COVID-19, as I mentioned, these relaxed policies have really been helpful. And I think it's something that we need to think about beyond COVID-19, keeping that elimination of the one-for-one needle exchange, keeping all these mobile outreach sites, decriminalizing drug use, and not punishing people for having more than 11 needles on them. I think these are all things that we need to consider moving forward. And also supervised injection facilities. As I mentioned, most of our study participants in the rural heart study were very in favor of supervised injection facilities, and given the high overdose risk and infection risk of our study populations, and just all the data behind supervised injection facilities, I think these are things that we should definitely be considering in Maine moving forward. So just some take-home points from all of this work we've done so far is that we definitely need to be continuing to expand SSPs in our state, including mobile units. And I know there's a lot of folks working hard to make that happen. Since the Rural Heart Study, in fact, there's been several more SSPs through Maine Access Points and Health Equity Alliance that have expanded through the state, which is fantastic. Again, supervised injection facilities should be considered, and also maintaining some of these relaxed policies, allowing peer exchange, mail delivery of equipment. I think these are all things we need to be considering in the long term. So I just wanted to acknowledge the study participants and the funders, as well as the study teams. It took a lot of people to make these studies happen. So thanks to the team. Here are my references. If any questions, please feel free to email me or reach out. Thank you.